So hopefully I can give it in one line, but then it's picking the patient that's the difficult thing. So my approach to this is pretty simple. I fix the Saunders 1, 2, and 3, and I do an open reduction internal fixation and fusion on the Saunders 4. So I'll tell you hopefully which patient to pick and why I've arrived at that conclusion. So Rick Buckley, I always give good credit for this because he did that study we talked about. And the clinical problems are obvious to all of us when you get an oscalcis fracture. They get stiffness and shoe wear problems, arthritic pain, and all sorts of other complications. So our classifications are really Essex-Lopresti and the Saunders classification that I use commonly to try and make my decisions, as I just told you. And non-op complications, of course, can lead to all these issues. And it doesn't mean you shouldn't treat the non-op. There's lots of patients that we treat non-operatively because they're not a patient that you want to operate on for a variety of reasons. Again, injury is quite significant. And then the complications, again, with non-op treatment can be malunion, and you have to decide how to treat that, whether you treat that with orthotics, fusion, or subtalar fusion and sliding wedge osteotomy. And the stiffness of subtalar joint arthritis are things we expect from these, either operative or non-operative. And last patient I had had bilateral oscalcis fractures. One was a Saunders 4, which we did no reduction internal fixation and fusion, and it went on to really good results. The other one was a Saunders 2, which we thought we were going to get with open reduction internal fixation. Went on, and about a year later required a subtalar fusion, and turned out okay. But I'd say the Saunders 4 is actually the better outcome of the two when you looked at as early recovery. So again, natural history, initial results were poor. When we started to treat them, we had bad wound issues and bad operative techniques, but I think the modern techniques of minimally invasive, the Saunders approach with waiting till the wrinkle signs in place, and whether they do better. I talked to someone yesterday and I said, I think my mini ones do a bit better, but I sort of pre-select those ones to say I can do those with the mini approach, and I don't need the big curve, so if you don't make the big incision, you tend to do a bit better, but you pre-selected in your own history. So I think the operative treatment restores anatomy. You want to return the patient to function and prevent arthritis. And the problem is, of course, when they have these severe injuries, you get chondral apoptosis, so you can get a very nice reduction and then watch this articular surface resolve on you over the next year or two. So what do? The operative treatment is lacking. Buckley did probably the best study, and it'll probably never be repeated, as we talked yesterday. The operative treatment of non-operative with operative treatment and a prospective randomized controlled multi-center study. And there's been many have repeated about that, but not to that same level. So this involved a lot of patients, as we talked about yesterday, but it's unlikely to be repeated because of the numbers involved. 424 patients randomized prospectively throughout many sites. So the problem was we looked at those results and we said we couldn't really tell what was better. So you had all these patients, 500 patients, prospectively followed for over 2 years. We couldn't really see any difference between them. But when we took out the workers' compensation patients or the litigious patients involved, then all of a sudden the sky opened up and you could see a difference. So if you take a patient that's going to do badly regardless, so my workers' compensation patients, operative or non-operative, how you doing? Awful. Can you go back to work? No. So that's your patient, right? So it doesn't matter what you do to that patient. He's going to turn out badly. So we had to take those patients out of the study. Once we did that, we looked at patients that wanted to go back to work, wanted to get better, and you could show the outcomes were significantly better in some of the groups of surgically treated patients. So other areas looked at these, again, smaller studies, but again showed operative were better than non-operative, and operative treatment successful and preferable unless contraindications exist. So what do we know? So what are the contraindications? So all of these things that I mentioned on the slide are contraindications, and most of them are relative. If you add them up, then they become horrible, right? And so the next study looked at just three, looked at diabetes, vascular insufficiency, and smoking. If you had one of those, it was bad. If you had three of them, the chance of problems with your wound was over 90%. So you got to look at your patient, say, I can fix this bony injury. is the soft tissue going to react to that appropriately or not? And if I'm going to use a soft tissue operation, should I use a mini invasive approach and get it pretty good, or do I have a maximally invasive approach and worry about the wound? So you have to kind of make that decision. So the decision about the bone, I think, is relatively easy. The decision about the patient is relatively difficult. So I think for an open fracture, I'll show you my treatment for that with an external fixator, and I think those are things you look at, again, percutaneous or external fixator for compound wounds. So a rational approach. So I think the best method remains controversial, and I think you have to assess each patient, as I mentioned, with the injury, the patient, the surgeon. Are you up to the task? Is the patient up to the task, and is the injury fixable? So I think look at this, whether you look at soft tissue sparing versus extensile approach, and many have written on this. I've worked with all these people, Branischka, Letournel, and Saunders, and they all do it a little differently, but they all respect the soft tissue appropriately. And how do you do that? Well, pre-op, you're going to do elevation, compression stocking, a cast boot, elevation. Now we do it outpatient, used to do it in the hospital, and wait till the wrinkle test was available, and if the patient can go home. I say in the hospital because some of our patients just don't know any place to go. They're without housing, and they have to stay in the hospital before they get better. So then you look at the wrong way. So then you go to the lateral and axial view and decide what you're going to do with the patient. Look at the CT scan, indicating the fracture line and how many fragments you have to deal with, and then do a lateral approach. And you can see in this one, we've really brought that width of the calcis down to a nice level and reduce the subtalar joint and anterior joint. So how do you do that? Do a lateral approach, basically trying to do the no-touch technique, go right down to the bone, elevate the flap up so you can gradually elevate it up, get rid of the perineal tendons and move them forward, and then get a pin in the crucial angle of the talus and also in the cuboid, and then elevate that so you can get the subtalar joint available. Either can flap out that fragment or sometimes just pops out as it did in this particular case. And then you get to look at the inside aspect of the joint and try and elevate the fracture fragment, clean it out and disimpact the sustentacular fragment, and then reduce posterior facet, start at the medial side and gradually work from the medial side to the lateral side with K-wires. I don't use absorbable pins, but some people do. I just use the pins. When I finally get finished, I take the pins out and replace them with screws. So reduce the posterior facet to the sustentacular tali, and then gradually restore the height, restore the valgus, and get some medial translation out of there if you possibly can. Once you get there, then you're into the point where you can get the pin reduced and then assess it radiographically. And depending on the number of pins you use, you want to get a good look at both the the lateral and the axillary view, and make sure you have that width right down to neutral and the subtalar joint reduced, and then decide what peripheral screw fixation plate you want to utilize. So other ways of doing it, there's a percutaneous approach, and I use this in the tongue type approach. Again, I sometimes combine them. I'll use a small Olier approach to do the subtalar joint elevation with a doer, bring that up, and then do an Lopresti maneuver to bring the os calcis down into a good position, and then do a percutaneous screw fixation. So again, you can see this being done, bringing that tongue type down. This is kind of the emergent situation where you get an os calcis that's elevated and the skin is compromised. You put your screws in, get that out of the way, and take the tension off the skin. And then once you get it reduced, then you put your screws in to hold it in good position. And this holds it nice, reduced position that looks good on both the AP and the axillary view. So I think operative treatment complications, unfortunately, they have all the same complications you had if you treat it non-operatively, plus you get those with apical wound necrosis and infection. So you got to make sure that you've saved that patient to the point where you think you have the best shot at doing an open external fixation without skin necrosis. So I think there's an advantage to open external fixation, mostly in the Saunders 1 through 3. And again, in selected patients, I don't just make the decision based on the x-ray. I also go see the patient. My residents and fellows will tell you, I go down and see the patient in emergency, walk in the door. About 2 minutes later, I walk out going, nope, that's not for us. This is going to be a casting, and we'll see him in clinic, So it's really a quick, but you have to look at the patient in the eye, look at his teeth. They look like met teeth. Probably not a good patient for you, So everyone knows what I mean when you say that. So this is a fun fracture, but about halfway through, you may want to do this with your foot or his foot. So just be aware that it can be frustrating. So this population is a very special group. They're poor decision makers with few resources. They smoke and they drink a lot, so make sure you evaluate your patient very carefully. So just to emphasize that. So non-operative care can be successful. Here's a patient that we treated, and you can see nice success, even though he has a bit of a valgus heel. He has a nice range of motion, no pain, so it can be a successful operation in the right patient, but it doesn't mean no treatment. Fusion is a good late reconstructive procedure. When you look at the numbers, 1 in 6 patients treated non-operatively probably are going to go on to require a subtalar fusion. Okay, 1 in 40 treated operatively are going to need the same thing. So you really raise your success rate with good operative fixation, again, in their correctly selected patients. So I think the results of late fusion come up to about 7 out of 10, which is not as good as a good open reduction internal fixation, but better than a failed closed treatment. So who to primarily fuse? Again, in Canada, we did a study looking at Saunders for either fuse or fix. We fixed them, or we did a fixation and fusion, and that's where I came to my conclusion with the study that we did. It was a bit reduced in the amount of power that we did for the patient. We didn't reach the numbers we wanted to, but it was quite clear trend in the patients that they got better. So by 6 months, they finished their whole rehab and didn't require another operation, versus the secondary group, some of them did well, but many of them required, like 1 in 6 or so, required a fusion and a secondary attempt. So they were a year or two getting better, versus the group that got ORIF and fusion were better by about 6 months. So that's why I do that. So here's an example. Patient fell off a ladder. You can see the big expansion, the tongue type up, and then the wide oscalosis that you see on the axillary view. And then you can see 3 pieces there indicating a Saunders 3, nice preoperative evaluation, and then bone graft is not helpful. If you use bone graft in these, Lieutenant taught me that many years ago. I didn't believe him. I tried to put a bunch of bone and calcium phosphate in it, and unfortunately, you put calcium phosphate in this fracture and it gets infected, you got to dig all the calcium phosphate back out again. So it's a very difficult chore to get the infection. So I would relate to you not to put things in the oscalosis, just to fix it peripherally and use your plate to hold the fixation. So use nothing to add to the space, and Lieutenant was right, as usual, and so we should have listened to him then. So here's the good peripheral fixation. You can see the screws all around the periphery where the bone's good. The middle of the bone, where you see that var going up, is holding your subtalar joint up, and by collapsing it down in the lateral view, you can see you got a nice alignment of the bone and good fixation. So here's another 25-year-old man. I just want to show a compound fracture. So transverse medial wound, what do you do with those? So very deformed, difficult x-rays to look at. And once you get the compound fracture evaluated and cleaned out, the treatment really, in my hands, is an external fixator. You can see it nicely applied here with good fixation. You let them put a bit of weight on it to get around, and then once the soft tissue is united, decide what you're going to do with next. And it may never be acceptable for an open external fixations, but you have someone that you can manage and treat and go as an outpatient and control the wound. So what do we know? We know that contraindications are many, and if they're additive and probably logarithmically added, they probably go up like this. They just don't go in a steady curve. So the more you get, the worse it is. And so these are the ones you should stay away from initially, or at least wait until the soft tissue allows you to go in and do fixation. And non-operative treatment does not mean no treatment. In their patients, an older patient, smoker and non-compliant, workers' compensation to litigious, heavy labor, medically unwell, bilateral. Am I getting to the point? This patient's not a good one for surgery, but you got to handle them in your clinic and get them going with a non-operative approach. And then eventually, if they do poorly, then you may want to do a fusion on them down the road, but not early on. And you can bring them back, as I said, to a 7 out of 10 versus about an 8 or 9 out of 10 for a good operative fixation. So again, I would fix the Saunders, to go back to my first statement, fix the Saunders 1 to 3, and those that are good for surgery. Don't perform till the soft tissue's ready. Minimally invasive is a good approach, I think, and coming on strong. You just can't get quite to the posterior border, but you can combine some percutaneous fixation with some elevation of the joint. So I think you can manage that in a nice manner in some patients, and keep them non-weight bearing till you're sure the soft tissues are good. It's not a bony decision to weight bear. It's what do the soft tissues look like, and am I happy for them to put some weight on that? And ORAF plus fusion, I think for the Saunders 4, for me, satisfies that injury and gets them back to activities the quickest. So thank you very much.